episode of our webinar series, proudly conducted by AMOGS Emergency Obstetrics Committee with Trivandrum, Kollam, Adur, Alappuzha and Kottayam Societies of KFOG. We are delighted to have you join us today for a very insightful session on emergency obstetric practices. This initiative is a brainchild of Dr. Sneha Bhuyar Madam, the esteemed chairperson of the Emergency Obstetrics Committee, whose vision and dedication have made this webinar series possible for us. We look forward to an engaging and informative session ahead. So as we move on with our program, please join us for the ceremonial lamp lighting, symbolizing the illumination of knowledge and the start of our inspiring event.
Kurutvang kalyanam arogyam dhanasampadam Shubham kurutvang kalyanam arogyam dhanasampadam Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvang kalyanam आरोग्यं धनसम्पदं शुभं कुरुत्वं कल्याणम् आरोग्यं.
It is my great pleasure to introduce Dr. Sneha Bhuyar Madam, a distinguished obstetrician and gynecologist whose accomplishments span an impressive area of awards and contributions. Madam has been honored with the International MS Signature Award for Phenomenal Leadership in 2020. In recognition of her outstanding work in rural obstetrics, she has received Dr. S.N. Malhotra Individual Award. Madam has also awarded the Dr. Duru Shah Distinguished Community Service Award. She's also been celebrated as a Champion of Foxy Award for 2 consecutive years. She's also received Dr. Anandibai Joshi State Award from the Government of Maharashtra. Madam's contributions to academic and professional community are substantial, and she has delivered over 300 talks, given more than 10 keynote addresses, and over 100 panels. And she has authored more than 30 chapters and articles in national publications. Her leadership roles include serving as a Foxy Breast Committee chairperson from 2019 to 2021. She is also a national adolescent trainer certified by WHO and FPAI, and the national expert for UNICEF. As a peer reviewer of the Journal of Obs and Gynae of India, Jogi, she contributes to maintaining high standards in academic publishing. Currently, Madam serves as the AMOGS chairperson for the Medical Disorders Committee and the Emergency Obstetrics Committee, and she is actively involved with the Mission Pink Health Committee and serves as the convener for PCPNDT. She is also a member of the KFOG working group on breastfeeding. Over to you, ma'am.
Thank you so much, Dr. Atulya, for that generous introduction indeed. A very good evening, and of course, a very good evening and my respect and regards to respected Dr. P.K. Sekharan sir, Dr. Kunju Mohiuddin, the President of KFOG, as chief guest for today's program, Dr. Aswat Kumar, immediate past President of KFOG, Dr. Subhash Mallya, the Secretary, as guest of honor for today's program, respected Madam Serena Gilwas, the past President of KFOG, Dr. Rani Lakshmi, the past Secretary of Kottayam Society, as speakers for today's program, our esteemed chairpersons, respected Madam P.K. Shamala Devi and Dr. Prasanna Kumari, both the past presidents of KFOG, and of course, Dr. Rachel Alexander, Dr. Vijay Lakshmi, our learned panelists, Dr. Kala Prapod, Dr. Rithi Rajan, Dr. Nimisha, Dr. Reena, Dr. Dipti, and Dr. Nurul Amin. Our conveners, Dr. Shama Devsdasan, our coordinator, Dr. Monica Umbadand, and Dr. Atulya, who is also the MOC for today's program. A very good evening and warm welcome to all of you on behalf of AMOGS, the entire team. Dr. Kiran Purtakoti as president could not join today because he is in Alaska. And of course, Dr. Bipin Pandit, Dr. Pardesi as immediate past president of AMOGS, Dr. Parag Biniwale as the national coordinator of AMOGS. Special thanks to Dr. Kunju Mohiuddin and Dr. Aswat and Dr. Subhash for the collaboration. Friends, as Emergency Obstetrics Committee, we are working mainly in the aspect of reduction in not only the maternal mortality and morbidity, but also the perinatal morbidity and mortality. We always, our aim should be every labor should result in the healthy baby from a healthy mother, and it should be a emotionally fulfilling experience to the mother. it has to be a respectful maternity care. And of course, we have Dr. Rani Lakshmi and Madam Serena Gilbas to guide us on these topics. And of course, the panel discussion on labor emergencies. I'm sure with these excellent faculties, it is going to be definitely a very informative session. And I'm sure that it will have, very good take-home messages. So with this, I welcome all of you, and I would like to invite Dr. Parag Beniwale on behalf of Dr. Kiran Kurtakoti and AMOGS for his few words of welcome, and of course we go ahead with the other speakers as well. Over to you, Dr. Parag.
Yeah, Sneha, Dr. Rajendra Singh Pardesi, immediate past president, is here. So I think he should be speaking first.
It's okay. Parag,
No, it's your honor. You are a
Please
immediate
go ahead,
past
Dr.
president.
Rajendra Singh Pardesi, sir. I think I did not see him. Please go ahead. In fact, we are waiting for your blessings and guidance.
Good evening, everybody. Respected Chief Guest, Dr. P.K. Shekaran, sir. So it's very nice to meet Dr. P.K. Shekaran, sir, for since a while. Dr. K.U. Kunjumoidin, with guest of honors, our friend Dr. Ashwat Kumar and Dr. Subhash Mallya, and our national coordinator, Dr. Parag Beniwale, and our president, Dr. Kiran Kurtakoti, Dr. Bipin Pandit. First, I wish to congratulate Dr. Sneha Boyar for organizing this webinar with Kolam, Adur, Alupaza, Kottayam societies. Dr. Sneha has chosen excellent topics. They are on basics, but important in day-to-day practice. That is WHO ANC guide and WHO labor care guide. They are the excellent pathways to reduce maternal mortality rate. I am proud of Kerala and Maharashtra state for their care for women's health, as they are on top to reduce maternal mortality rate. And with the eminent faculties like Dr. Rani Lakshmi, Dr. Serena Gilbas, and Dr. Sneha Boyar, and chairpersons, panelists, this is going to be a great event. I wish every success to Dr. Sneha Boyar for a future endeavor in FOGSI as Vice President of FOGSI in these forthcoming elections. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you. Thank you.
Thank you, sir. Thank you so much. In fact, we were waiting to listen to you. And thank you for your blessings and guidance. Now I invite, I think, Parag, in fact, I would like to express your thanks on behalf of AMOGS, and I would like to have Dr. P.K. Shekaran sir's speech first as chief guest. So all of us know sir as the past vice president of FOGSI, and of course, a very revered teacher of teacher. He is a past president of Kerala Federation also, but without wasting much time in introduction, we would like to listen to your precious words, sir, and over to you for the same. Thank you so much.
Thank you. Thank you. Thank you for your invitation, first of all. I was, of course, you could not meet me because of my travel, and thank you again for inviting me. Now, I could see that many of our important societies in Kerala are involved in this meeting, and we have got the Trivandrum, Kollam, Adur, Alappuzha, Kottayam, and Kottayam societies representing in this seminar. The topics are very interesting in the way that the WHO labor care is, again, to understand what it is. It's basically on the respectful maternity care, which people are not still giving that respect. So I am afraid that we have to know what it is. And we could see that many of our colleagues from Kerala are there. Our present president, Dr. Kunjumoidin, our past presidents, Dr. P.K. Shamla Devi, Dr. Prasanna Kumari, Dr. Serena Gilbas, and our secretary of the KFOG is also there, Dr. Subhash, and Dr. Ashwat Kumar. So most of the leaders of our federation is present here and given the role. And I could see that it's an important webinar because the obstetric care, if it is not improved well, our maternal mortality will not come down. I think that almost 1/3 of the maternal death is directly due to the intrapartum care and its problems. So it is important to understand where we are going wrong, how to reduce the incidence of maternal mortality and morbidity and perinatal loss. So all important aspects of the maternity care comes in the actual field of the intrapartum care, and we could see that many of these faculties are going to make us wiser, and hope that and wish all the best for the webinar, and also best wishes for you, Dr. Abhiya, and thank you once again.
Thank you so much, sir, for your precious words, and that has really thrown light on this topic. May I invite Dr. Kunju Mohiddin, who is the current president of KFOG, and of course, I would say, the busiest person, very difficult to communicate with you, and we are so fortunate to have you, sir, here. So we would like to have your words of wisdom and guidance for us.
Yeah, respected Dr. Sneha, ma'am. I still remember the days during the my president as Perindalmana ONG Society. That time you were the breast committee chairperson. We had done a lot of competitions. We had done a lot of activities during that time. I still remember the good times. And the respected leaders of the AMOGS, my dear Sagaran sir. In fact, we both were in another webinar an hour back in the same assignments. And now at 7 p.m. we are with this webinar by the AMOGS on emergency obstetrics. And whatever, however much we discuss, it won't be an excess when coming to the topics of emergency obstetrics. Because the things are changing, the perceptions are changing, the patient's communication parts are changing. So a lot of things are keeping on changing. And the most important challenge is the lack of the what you call the privileges and lack of the capabilities and the skills, specifically the skills of the obstetricians or the gynecologists who are just being passed out from the institutions. So with this, because very often when we interview the people, they may not have even done a full cesarean section. So that is the state of affair of the postgraduate people who are coming out. So just to cover up that, the Kerala Federation has formulated a program called TOPS, that is Training of Obstetric Procedures Skill, that is on the simulator models, and that program is being conducted regularly at regular intervals. And the master brain behind that is the 3 pillars of KFOG, that is Dr. Paili, Dr. Sagaran, and Dr. Rajsekaran sir. So they are the people who are holding the full mantle to have this program percolated to the entire length and breadth of Kerala. So with these few words, I wish this webinar a grand success and more grand and thumping victory for our dearest Sneha Buyar, Madam, as the President of FOGSI and Vice President of FOGSI, and hope we'll be able to have more academic programs in your position as Vice President of FOGSI West Zone, and wish you all the success. Thank you so much. And with all our support.
Thank you so much. Thank you so much, obliged. And it indeed a pleasure having your association guidance and of course wholehearted support. Thank you so much, Dr. Kunju Mohiddin. We now go ahead to have precious words from Dr. Parag Beniwale, who is the national. I have just said Dr. Ashwath and Dr. Subhash. I'm sorry, both of them are not available. Ashwath, Dr. Ashwath is having high-grade fever. He just expressed his apologies, but he will join in the next program. That is what he has promised. And Dr. Subhash is operating. So we will just have quickly Dr. Parag Beniwale, who is the national coordinator of AMOGS and of course the chairperson-elect of ICOG, very dear friend. Over to you, Dr. Parag, for your precious words.
Thank you, Sneha. Good evening. I bring greetings from AMOGS, and as the national coordinator, it's always wonderful to collaborate with other state societies, and I must thank Dr. Kunju Mohiddin and the KFOG for collaborating with AMOGS. Of course, I must acknowledge presence of immediate past president of AMOGS, Dr. Rajendra Singh Pardesi, and of course all stalwarts of KFOG, starting from Dr. Shekharan, Dr. Shamala Devi, Dr. Prasanna Kumari, and of course our dear favorite teacher, Dr. Sarina Gilwas. Thank you all, and thank you, Dr. Rani Lakshmi, for agreeing to be part of this program. Sneha, I'm particularly happy because this interaction is between the number 1 and number 2 states of who are the best in maternal mortality. So whatever discussion that takes place should be passed on to other states because they need it more than Maharashtra and Kerala. And there's a lot to learn from our friends from Kerala because they have far more systematic programs in place, including the Maternal Death Review Committee, which is supported by KFOG. So thank you very much for all the Kerala societies, Trivandrum, Kollam, Alappuzha, Kottayam, and Adur for joining. And my best wishes for the program, Sneha. I'm very happy that Dr. Kunjam Mohiddin has, very openly supported you. Let's hope for the best and best wishes to you.
Thank you so much, Parag. In fact, let me share with you that I'm really very fond of KFOG because there's lots to learn from all these leaders and the obstetricians. As previously, we have organized one program with KFOG that was from 82 to 28. And I was thoroughly impressed with the team of KFOG stalwarts who have shared their experiences in reduction in maternal mortality. So with this, I thank all the respected dignitaries for their gracious presence and your precious words as well as blessings to me and the program. We just looking forward for the very interesting academic session, which is going to be very, very informative, and of course, I would say it will be a long-term learning as Madam Sarina Gilwas and Dr. Rani Lakshmi is here as speakers. So wish you all a very great learning, and over to you, Dr. Atulya, for the academic session. Once again, I thank all of you and go ahead with the academic session. Thank you so much.
Thank you, Madam. So moving on to our first session on WHO Antenatal Care Guide. As chairpersons, we have Dr. P.K. Shyamala Devi, Madam, and Dr. Rachel Alexander, Madam. Shyamala, Madam, was a professor and head of the department, Obs and Gynae, Kottayam and Trivandrum Medical College. She is currently working in KIMS Health Trivandrum as senior consultant. She was a former president of KFOG, and she has actively participated in all academic activities, her main areas of interest being high-risk pregnancy, oncology, maternal mortality reduction, and medical education. Dr. Rachel Alexander, she's additional professor, Government TD Medical College, Alappuzha. She's the organizing treasurer of AKCOG 2024. She was a former secretary of ONG Society, Alappuzha, and a former joint secretary of KFOG. She was also the organizing secretary of AKCOG in 2014. I request Shyamala Madam to introduce our speaker for the first session. Shyamala ma'am.
Good evening to all of you. First of all, thanks for making me as a part of this event. And as you know, Dr. Rani Lakshmi is going to be the first speaker on antenatal care based on the 2016 WHO ANC guide. She is Associate Professor at Department of Obstetrics and Gynecology, Government Medical College, Kottayam, Fellowship in Advanced Obstetric Ultrasound and Fetal Echo, past Secretary, Kottayam ONG Society, and areas of special interest at fetal medicine. Over to you, Rani Lakshmi, for the deliberation.
Thank you, Madam, for that words. And thank you all the organizers for inviting me for the talk. And I'm actually because I'm presenting in before my teachers, Shekaran sir, Prasanna Madam, and also one of the best teachers, Dr. Sarina Madam, is coming after me. I had my UG and PG at Calicut, so I was with Shekaran sir and Prasanna Madam, and I know all senior madams like Shyamala Madam and all. They are all very senior to me. Okay, I'll start sharing my screen. Am I visible?
Not yet. Sahiti, can you please help her?
Oh, hi, ma'am. Can you please click on green color share screen button?
I had clicked on that only.
Yeah, after that you need to click on share.
Okay. Well, first I had to click on share, no?
Yes,
Yes,
ma'am.
Okay.
share screen, the green color icon at the bottom.
Now I can't see my presentation.
After clicking on share screen, you need to click on screen option, ma'am, which is on the top left,
Okay, okay.
and then share. Yes, ma'am. Now open the
Yeah.
PPT, ma'am. We can see your screen, ma'am. Minimize this window and so that you can open the PPT. We can see the presentation, ma'am. Please make it as full screen.
Okay.
Perfect.
Yeah, perfect.
Okay. So my topic is actually a big topic, WHO ANC guidelines. I'll quickly rush through the recommendations only, but as such it is 60 slides. So this ANC guidelines include 39 recommendations which is adopted by the guideline development group and 10 recommendations which is relevant to the antenatal care that have been consolidated into this guideline from other existing WHO guidelines recently approved by the GRC. So the interventions include nutritional interventions, maternal fetal assessment, preventive measures, interventions for the common physiological symptoms, and health system interventions. I'll go through each one by one. Nutritional interventions include dietary interventions, which includes counseling on a healthy eating and physical activity. So counseling about a healthy eating and keeping physically active during pregnancy is recommended for pregnant women to stay healthy and to prevent excessive weight gain in pregnancy. This includes a healthy diet, a healthy lifestyle, and choosing activities with minimal risk of loss of balance and fetal trauma. As you all know, the normal gestational weight gain should be chosen according to the pre-gestational BMI. So women who are underweight can gain up to 12.5 to 18, whereas obese women should gain only 5 to 9 kg. Next is an nutrition education on the energy and protein intake in undernourished population. So the recommendation is in undernourished populations, which is calculated by the BMI, nutrition education on increasing daily energy and protein intake is recommended for pregnant women to reduce the risk of low birth weight neonates. Okay, next is the energy and protein dietary supplements. First was a counseling, second was education, and next is supplementation of energy and protein dietary supplements. So in undernourished populations, balanced energy and protein dietary supplementation is recommended for pregnant women to reduce the risk of stillbirths and SGA neonates. So we have to have a quality assurance to guarantee that the food supplements are manufactured, packaged, and stored in an uncontaminated environment. And also to mitigate the cost effect, we should offer local production of these supplements. That should also be there should be a monitoring system to evaluate the household storage facilities, spoilage, wastage, and sharing of food. And to improve the delivery, the women should increase their additional visits. Next is high protein supplements. Are they recommended? So in undernourished populations, high protein supplementation is not recommended for pregnant women to improve their maternal and perinatal outcome. So first was the nutritional intervention. First came the dietary. Next is the iron and folic acid supplementation. As you all know, daily oral iron and folic acid in the dose of 60 mg iron and 400 microgram folic acid is recommended for pregnant women to prevent anemia, sepsis, LBW, and preterm birth. So is there something called intermittent oral iron and folic acid supplementation? There is an intermittent oral iron of dose 120 mg and 2800 microgram, that is 2.8 mg folic acid, which is given weekly to the women in population with an anemia prevalence among less than 20% in patients who are not accepting a daily iron due to side effects. What about calcium supplementations? Of course, in population with a low dietary calcium intake, daily calcium supplementation in the dose of 1.5 to 2 gram oral elemental iodine is of course recommended for pregnant women to reduce the risk of preeclampsia. Next comes the other supplements like vitamin A, D, E, C, etc. You can see none of them are routinely recommended. Vitamin A supplementation is recommended only for those pregnant women in areas where the vitamin A deficiency is a severe public health problem. Zinc supplementation is only recommended in context of rigorous research. What about multiple micronutrients? They are also not recommended for pregnant women to improve maternal and perinatal outcomes, although they have shown some benefits. Vitamin B6 supplements is also not recommended in women to improve maternal perinatal outcomes. Vitamin E, C, and D supplements are also not recommended in these women to improve the maternal perinatal outcome according to the WHO guidelines. Of course, WHO recommends restricting the caffeine intake up to not more than 300 mg per day in all these pregnant women to reduce the risk of pregnancy loss and LBW neonates. Next comes the maternal and fetal assessment. So first was the nutritional intervention. Now comes the maternal and fetal assessment. So maternal assessment, first you have to detect anemia in these patients, and the recommended test is a full blood count testing. And when a full blood count testing is not available, WHO recommends hemoglobin testing using a hemoglobinometer than a use of a hemoglobin color scale for diagnosing anemia in pregnancy. Next important assessment is for asymptomatic bacteriuria. A midstream urine culture is recommended for diagnosing asymptomatic bacteriuria or ASB in pregnancy, where urine culture is not available. If urine culture is not available, and you can use a midstream urine, gram staining is recommended over the use of dipstick. So either a midstream urine culture or a midstream urine gram staining is recommended for asymptomatic bacteriuria. This is a new thing. Not a new thing, but this actually comes under the WHO guideline. We have to inquire about intimate partner violence if we suspect that there is the patient is depressed, there is some suicidal tendency in the patient, or the patient hesitates to give the actual history. We have to, in private and in confidence, we have to elicit an inquiry about an intimate partner violence. This is a WHO recommendation. Next is the GDM. Hyperglycemia first detected any time during pregnancy is classified either as GDM or diabetes mellitus in pregnancy. We have to ask all pregnant women about the past and present use of tobacco and also exposure to passive smoking. Substance abuse such as alcohol and other substances, past and present history should be elicited. And in HIV prevalent settings, we are usually following that a provider-initiated testing and counseling is recommended in high prevalence areas. So what is the advantage is that there is a pre-test counseling. They can decline testing. They can understand what's the relevance of the testing, and the maternal to child transmission can be reduced. All these are provided by this provider-initiated testing and counseling. In low prevalent areas also, this provider-initiated testing can be considered for pregnant women in antenatal care settings to reduce MTCT and also to integrate HIV testing with other viral infections and syphilis. Tuberculosis checking or screening for TB is recommended only in populations where the prevalence is as high as 100 per 1 lakh or higher. Now, the fetal assessment. Most of the tests we recommend in fetal assessment was unfortunately not recommended by the WHO. What does WHO say about daily fetal movement counting? They can say that we can educate the patient about the fetal movement counting and also ask them to report if they feel a reduction in movements. But as such, a count to 10 recommendation, a kick chart is only recommended in context of rigorous research. Symphysis height. They're saying replacing abdominal palpation with the SFH measurement is not recommended to improve perinatal outcomes. But if you're following an SFH measurement, better not to switch it to abdominal palpation. Coming to antenatal cardiotocography, it is not recommended. Coming to an ultrasound scan, what WHO is recommending is an ultrasound scan before 24 weeks to estimate gestational age, improve detection of anomalies, multiple pregnancies, and to reduce the induction of labor for postterm pregnancies. If the patient has had a scan before 24 weeks, another scan for detecting these anomalies is not recommended. Of course, you can use it for detection of location of placenta, liquor volume, and growth. Routine Doppler ultrasound examination is not recommended. Now coming to the preventive measures. So second was maternal and fetal assessment. Third is preventive measures. So for preventive measures, one is you use antibiotics for asymptomatic bacteriuria. A 7-day antibiotic regimen is recommended for all pregnant women with asymptomatic bacteriuria to prevent preterm birth and low birth weight. Now, do we recommend antibiotic prophylaxis to prevent recurrent UTI? A recurrent UTI antibiotic prophylaxis is only recommended in the context of rigorous research and it is not routinely recommended. Antenatal anti-D immunoglobulin prophylaxis in a non-sensitized RS-negative pregnant women is also not recommended, although they recommend the postnatal anti-D prophylaxis. Preventive and anthelmintic treatment is recommended in endemic areas. They recommend a 400 milligram of albendazole or a single dose of 500 milligram albendazole after the first trimester to reduce worm infection. TT vaccination is recommended for all pregnant women. Of course, we give TD. It is recommended for all pregnant women depending on the previous tetanus vaccination exposure. Now, there is intermittent preventive treatment of malaria in pregnancy, where in Africa and also in areas where there is a high prevalence of malaria or malaria endemic areas, sulfadoxine pyrimethamine is recommended after the second trimester for 3 doses given 1 month apart. Next is pre-exposure prophylaxis for HIV prevention is recommended by WHO. The tablet tenofovir is recommended. Additional prevention for women who are at substantial risk of HIV infection, that is 3 per 100 women is. If there is such as high risk as 3, we are recommending a pre-exposure prophylaxis. Now, what are the interventions we give? WHO is recommending for our common physiological symptoms. So, for NVP or the nausea and vomiting of pregnancy, they are recommending ginger, chamomile, vitamin B6 or acupuncture for the relief of nausea based on a woman's preferences. Pharmacological treatments such as metoclopramine and oxalamine are recommended if the patient has distressing symptoms. Interventions for heartburn, again, advice on diet and lifestyle, like reducing the fatty diet, sleeping with the head up on a pillow. All these recommendations are, and having small frequent meals are recommended to reduce heartburn in pregnancy. And the drug of choice recommended was antacid preparations that are not relieved by lifestyle modification. For leg cramps, again, magnesium and calcium was found to be of benefit and they didn't do any adverse side effects when given for leg cramps. So they are recommended 300 milligram calcium and 1.5 to 2, 300 milligram magnesium and 1.5 to 2 gram calcium, or non-pharmacological treatment like massage, immersion in water, keeping the leg elevated are recommended for leg cramps. Interventions for low back and pelvic pain. Regular exercise throughout pregnancy is recommended to prevent low back and pelvic pain. There are a number of different treatment options such as physiotherapy, support belts, acupuncture based on her preferences. Interventions for constipation. We advise the patient to take plenty of water and fiber-rich diet. If not, she can use wheat bran or the other fiber supplements can be used to relieve constipation in pregnancy. That is best recommended. Though lactulose and other laxatives like bulk forming are not contraindicated, but they should not be given with iron and calcium supplementation because it will reduce the absorption. Interventions for varicose veins, again non-pharmacological options such as compression stockings, leg elevation, water immersion, and keeping the leg elevated is recommended. Now, what are the health system interventions you can use to improve the utilization and quality of your antenatal care? I think this is the most important part that our policy makers and stakeholders have to concentrate upon. Women held case notes. It is recommended that each pregnant woman should carry her own case notes during pregnancy, be it in paper or which is easy to carry for the patient, or if it is electronically available, she should have the technology to access her notes. This is necessary to improve the continuity and quality of care. Next is if we have a good midwifery program, it is one of the best care that we can give our patient, that midlife-led continuity of care models in which a non-midwife or a small group of non-midwives support a woman throughout the antepartum, intrapartum and postpartum are recommended for pregnant women in settings where there is a good midwifery program. Another thing is a group antenatal care. This is we are following in our medical college and all, whereas a group antenatal care is provided by qualified healthcare professionals as an alternative to individual antenatal care. It doesn't substitute an individual antenatal care. This is beneficial when we can educate a group together and they get a peer support and they get a peer group and additional educational information where a healthcare provider is educating a group of antenatal women in the OP and they're classified according to their same gestational age or same kind of symptoms like GDM, PIH, anemia patients like that. They can be grouped. Now is the community-based intervention to improve communication support. There is something called facilitated participatory learning and action cycle with the women's group. This means in a particular community, we'll identify a certain group of women group. They can be educated upon how to identify the high-risk women or a particular group of women, how to educate them. We can involve their participation in our improvement of the maternal and child health improvement. Now, another is the antenatal home visits that we are following in Kerala for past many years. We have our antenatal home visits. So packages include household and community mobilization, and antenatal home visits are recommended to improve the antenatal care and perinatal health outcomes in rural settings with low access to health services. Now, what is staff shifting? So we all know that we are at a shortage of staff. So doctors can't sit for hours counseling our patients, especially in government setting. So there's something called a task shifting. We can shift our tasks to a broad range of cadres, including health workers, nurses, midwives, and all. And also the distribution of recommended nutritional supplement and intermittent preventive treatment in pregnancy for malaria, all can be shifted to broad range of cadres, including nurses and midwives and other doctors. So one of the most important and the last slide of this presentation is the recruitment and retention of staff in rural and remote areas. What policymakers should do? Policymakers should consider education, regulatory, financial, personal, and professional support intervention to recruit qualified health workers in rural areas. Actually, these are the few recommendations: to enroll students with a rural background in education programs for various health disciplines, and setting up a healthcare professional school outside major cities. And you have to revise your curricula. We have DRP postings, and our PGs are having clinical rotations in rural health areas, which help them to understand what is going on in the rural health area and which can enhance their competency to work in a rural area. We have to improve the living condition of the health workers and their families so that they choose to work in the rural areas. This can be done by policymakers only. They have to be provided a good and safe working environment. We have to do outreach activities. This has also been implemented in Kerala. We go from a outreach to rural areas. So this leads to a better cooperation between health workers in different areas. From a very better served areas and underserved areas have a better cooperation. And also career development programs for this rural area. This National Health Mission has already undertaken such career development programs for health workers in the rural areas in giving them additional education and training. Next is a professional network. We all know now we are using this telemedicine and all for giving professional support. And there are rural health professional associations, journals, etc. should be provided to improve the morale and status of the rural health providers, so that there can be the feelings of professional isolation for these group of health workers can be reduced. And also we can boost up their morale by adopting public recognition measures such as rural health, celebrating rural health days, giving them awards, titles at local, national, and international levels to lift their profile. So last is the antenatal care conduct schedules. So antenatal care models, the latest WHO recommends a minimum of 8 contacts to reduce perinatal mortality and improve women experience of care. The previous recommended was 4 visit focused ANC, and the term visit was taken by the WHO, and they are given the term contacts, and 8 contacts are needed to improve the health status of our pregnant women. Thank you.
Thank you, Madam. I now request Dr. Rachel Alexander, Madam, to conclude and say a few comments on the first session.
So it was really an informative talk, and very elaborative also, Dr. Rani Lakshmi. You have covered all the aspects very clearly and in a specified manner. And thank you for the great effort.
Thank
You
you,
have put.
madam.
Thank you, Rachel ma'am. Shamla ma'am, can you please add a few comments?
Because what we are practicing is a little more different from this, isn't it? According to the WHO guidelines, so I think we can change according to our situations, our population. 24 weeks is the first scan they suggest. See, most of our patients are coming with pregnancy test and the dating scan to us. So we usually insist on first trimester screening for a pre-eclampsia, aneuploidy screening, and we do the anomaly scan at 20 weeks so that they can have time for termination of pregnancy. So there's a lot of change, but we can attribute the changes according to our situations, our patient population, all this they can afford. We should not completely copy the WHO guidelines. I think we can make our own changes. From 8 visit, I think all of you, even in Kottayam Medical College, in all medical college, it is not 8 visit. I think we go up to more than.
Madam, it is mainly aimed at the rural population of considering the whole of India. And Kerala is not, they are all doing all the antenatal checkups. Mainly they are recommended according to the rural population, madam. They are recommended according to the population.
That is I told you, the recommendation, okay, but we are practicing in a different, even in rural areas and public hospitals also, they are following the same KFOG guidelines.
Yes, ma'am.
Or KFOG has put in a guideline for antenatal care. They are following in all the, even in primary health centers, cardio hospitals, everything. That is why we could bring down our maternal mortality to such a low level.
Thank you, madam.
I also went through this, but when we come to the last portion, I put in. Thank you.
Thank you, madam. We'll now move on to our second session on the WHO Labour Care Guide. As chairpersons, we have Dr. Prasanna Kumari, madam. Madam is the head of the department and senior consultant obstetrics and gynecology, Lifeline Hospital, Adoor. She is a senior consultant obstetrician and gynecologist at SUT Hospital, Trivandrum. She was a former professor at Government Medical College, Calicut and Trivandrum. She is the author of a postgraduate gynecology textbook and awarded the WHO fellowship in 1991. She was also the former president of KFOG. We also have Dr. Vijayalakshmi MK, madam. She's a senior consultant OBG department, Travancore Medicity, Kollam. She was a past president of BIMA, Kollam, past secretary, OBG Society, Kollam from 2004 to 2007, her areas of interest being high-risk obstetrics and general surgery. I request Dr. Vijayalakshmi ma'am to introduce our special speaker for the session.
A very good evening to all. Thank you, ma'am, Dr. Sneha Buer, for making me a part of this event, and Dr. Atulya for introducing me. Next topic is Labour Care Guide, and the guest speaker is Dr. Sarina Gilvas, Professor and HOD, Jubilee Mission Medical College Hospital, Thrissur. And she's a winner of A.L. Mudaliar Gold Medal for MT from Kamaraj University, Madurai. And she's a faculty for UG and PGs since 1994. And she has written many chapters.
Madam, it's okay.
And to me, I know her, she's very simple and elegant and competent clinician, expert surgeon, and passionate academician. Over to you, madam.
Thank you.
Dr. Sarina, I think you are muted. Dr. Sarina?
Yeah. Can you hear me?
Yes, ma'am. Ma'am, please make it as full screen, ma'am.
Yeah, I'm just.
Yeah, madam is trying that only.
Is
Yeah,
it okay?
correct, ma'am.
Yeah.
Yeah,
right.
fine.
Perfect, madam.
Okay. So at the outset, let me actually congratulate Dr. Sneha for holding such a wonderful webinar. And Dr. Sneha, wish you all the very best in your standing for your post for Vice President of the West Zone. I'm sure you're going to win it. You have no doubt.
Thank you, madam. Thank you.
Dr. Shekharan sir, Shamla madam, Dr. Kunyamoideen, Dr. Subhash, Dr. Ashwath, Dr. Shama, Dr. Rajendra Singh Pardesi, Dr. Parag, and my chairpersons, Dr. Prasanna madam and Dr. Vijay Lakshmi. I think I'll start with my presentation of labor care guide. Now, for us to understand the labor care guide, I think first we must understand the partograph. Now, we all know from yesteryears that the normal labor characteristics had this preparatory division, which included the latent phase and the acceleratory phase. Then there was a phase of dilatation. And then there was the pelvic division, which consisted of the early deceleration and the second stage. And then Friedman drew the curve in which there was a latent phase, which was about 8 hours. And we started the active phase from 3 centimeters. Okay, we all remember those days. And we also appreciate that the partogram all these years has served us as an excellent tool in labor, where all the characteristic features could be written on one single page. So just one look at the page and we understand everything about our patient. Then came a change in that there was a WHO's composite partograph. I think this is something all of us are very used to, in which the first part, we have got all the details about the patient, her age, etc., etc. Then we have got all the details about the baby, the fetal heart rate, the caput, the molding, we know that. Then there was the most important part, which was the middle part, which was actually the dilatation and the descent of the head being marked. Then we had the number of contractions in 10 minutes. It was always calculated per 10 minutes. And looking at it, we could see if it was less than 20 seconds, it was marked as dots. The duration was between 20 and 40 seconds. We had the slash. And if the duration of the contraction was more than 40 seconds, we had completely dense squares. Okay, so looking at it, we could just say in this 10 minutes, in this, we have got 2 contractions between 20 and 40 seconds. Okay, it was so easy for us to calculate. Then we had all the details about the medication, and then the pulse, BP, urine, etc., etc. So this was something which we cannot forget and we should not forget. Okay. Then came the modified partograph. From the composite, we had the modified. What is a modification? WHO modified this partogram and she said, put a stop to the latent phase, because with that latent phase, which we said was 8 hours, we did a lot of unwanted interventions. And so WHO did away with the latent phase and started the alert line or the active phase of labor from 4 centimeter dilatation. And 4 hours after that, or 4 boxes after that, because each box is 1 hour, 4 boxes after that was the action line. And then we had the maternal and fetal parameters, okay? Now, this was a big change because we did not know how to do away with the latent phase because we were always hanging on to the latent phase, okay? And we always said that normal labor should fall on the left of the alert line. And if it crossed the alert line, then we have got, if you are in a primary health center, maybe you're required to change it to the next higher center. And if the labor progress crossed the action line, we said we had to take some action, either give sedation or oxytocin or maybe instrumental delivery or take a decision on CS. Some action had to be taken, okay? We cannot forget that either. Then based on the data obtained by Zhang and colleagues from the Consortium of Safe Labor, a different partogram from the Friedman's curve was drawn. And then the ACOG said that cervical dilatation is less than 1 centimeter. It's not that 1 centimeter per hour, it is much less, it is much slower. And therefore, the active phase must begin from 6 centimeters. Believe me, there are many centers which follow this, okay? Because I know of my niece was in the United States. She was actually a neonatologist. And, she was a second gravida. She went to the labor pains. And when she went to the labor room, she was sent back saying, you're not in active labor as yet. And then again, her pains increased. And when she went back, she was about 4 centimeters dilated. They again sent her back home and said, you're not yet 6 centimeters. Then her mom, who was a gynecologist who was sitting at home, said, if you deliver at home, I'll catch your gynecologist by the neck. because they were following this rule of 6. But there are people who still follow that rule of 6. Okay, but then the WHO came to a wire media between the 4 and the 6 and put the active phase beginning at 5 centimeters. And that's what we followed today. So the alert line, they said there should not be any graphic representation. So they did away with the alert line. So the line is gone, but the alerts have not gone. Okay, I'll show you the alerts. So the alert line had to be done away with. And they said to give an identity to the woman, to give a respectful maternity care. And all these things put together, the WHO brought about the next generation partograph. So the WHO partograph, which is modified in the light of the observations of Zhang and with the BOLD project by WHO, that is a better outcomes in labor difficulty. After this, they brought about this. And they said you can have an e-partogram, that is an electronic partogram. You can have a tablet-based application. You can have real-time decisions taken and all the entry can be made, etc., etc. So there were a lot of things that came out. But when the WHO came out in 2018 with the next gen, now we are always talking about the new gen, the next gen, etc. Okay, so that is the WHO's next generation partograph, which is the labor care guide. Now, the labor care guide developed to improve women's childbirth experience and to offer supportive care. They gave a lot of importance to this word supportive care. Plus, they identified and addressed the emerging labor complications. So that was not ignored either. And most importantly, unnecessary interventions. Now, I don't know what they would say if they knew about our pre-induction cervical ripening and all that. All that was done away with. They did a support audit and improved the quality of labor management. So all these were the concepts which came into the labor care guide. It was primarily designed for low-risk pregnancy, but the high-risk women may require additional and specialized monitoring, probably in bigger centers. So as I told you already, the labor care guide monitoring or the marking on it starts only from 5 centimeters, regardless of the parity or the membrane status. Okay, that's very, very important. The second thing is, once started, the LCG supports continuous monitoring through the first stage and the second stage. Always, we never had the second stage monitoring in the partogram. Okay, but here the second stage is also included. And the LCG is designed for use at all levels of care. I heard Shamla madam tell us about, we in Kerala, we are slightly better off. Yes, we are better. But this, they say this can be used in all levels of healthcare facilities. And the plan of action will depend on the level of care. And do you know one very important thing which they said and which I think is very true? Many times, which I must also confess, even in our hospitals, the partogram is marked after the baby is born, which can never happen with an LCG. It has got just a dynamic marking. It has got to be done then and there. Many times, what do? After everything is over, madam will come next day morning and ask, so the partograph is already marked and kept after the delivery. That's what is being done. Okay, that cannot be done. And they have implicated that also. So it helps early identification of potential complications and contribute to timely referrals when required. And when you look at this, it looks like a very crowded slide, but I'll simplify each section for you. Okay, so the structure of the WHO's labor care guide came into existence in 2018. And there have been various manuals. The manuals have been upgraded. Okay, the manuals you've got 18, 21, and 22 and all that. And it is called the next generation partograph. So as I told you all, the guiding principles for the WHO's intrapartum care model is labor and childbirth be individualized and woman-centered. See, they gave a lot of importance to this woman. No intervention without a clear medical indication. Without an indication, no doing anything unnecessary. Only interventions proven to be beneficial and a positive childbirth experience for all women, the newborn and her family. See, it has got a horizontal line which will tell you about the time. Okay, the horizontal time area, and you've got a vertical reference. I'll tell you everything about it. For determination of any deviation from normal, plus there is a second stage section. And when do we start marking it? From 5 centimeters. That is the active phase from WHO's point of view. to be used at all levels of care for early identification of complications and timely referral. There are 7 sections. And most importantly, which contains a list of labor observations. This is section 1. Okay, I've actually broken it up. For that, in the first part, this has got to be filled only once. So this is not dynamic. Okay, as soon as the patient comes, she's 5 centimeters, and then you start the marking. You write her name, her parity, the labor onset, the active labor diagnosis, when she had ruptured the membranes at time, any risk factors, all that should be documented, should be written down. And you saw the time there. Every column is actually 1 hour, 1 hour. And believe me, WHO also said that after 5 centimeters, a primary does not take more than 12 hours and a multi does not take more than 10 hours. And then when you come to the second stage, it's never more than 3 hours. So there was a lot more thinking into it, I guess. So after 5 centimeters, you'll find there are only 12 boxes, the 12 hours. This section is to be completed when active labor is diagnosed. Then you've got the second section. Now, this is respectful maternity. RMC, I think all PGs must know this word. It is the core component of the WHO's intrapartum care recommendation. Okay, it is a woman-centered care. And look at that column there, okay? There is, you saw that alert, so they have done away with the alert line, but the alerts are there. Alerts are there, okay? And when it is marked N, it is no. When it is Y, it's a yes. And so on. Those are the abbreviations that have been given. So look at the supportive care. It is good to have a woman in labor have a companion, whether it be the husband or sister or mother or friend or neighbor, anybody is acceptable in the first and second stage. And if there is no companion, it becomes N. So what is that? It's an alert. If it was Y, it was not an alert, okay? Do you know what that really means? If she has no companion and if she's come at 8 o'clock, I mark the time as 8 o'clock on top and I write N, which is an alert, and I circle it. That circling is what makes it, it will stand out. If the patient is given pain relief in the form of opioids or epidural can be given. If it is a Y, it's not an alert. But if she's got no pain relief provided, it's an N, it's an alert. Now, we should normally allow our patients to be mobile, give them oral fluids. So if it is not oral fluids and you're giving a parenteral fluids, then again, that's an alert, N, okay? N stands for no oral fluids. And a posture, if she's the supine posture, that means you're told to go lie down in bed. That's again an alert. A patient in the first stage, if she has got no risk factors and if she's perfectly okay, she should be up and mobile. So that is what the alert stands for. So you take and mark that at the time. Okay, if she's at 10 o'clock in the morning, she's come, then you mark it at 10 o'clock. If she's got a companion, yes, Y. If she's got pain relief, it's Y. No alerts. If she's on oral fluids, fine, it's a Y. If she's walking about, it's a Y. Do you understand? So those are all, that is the importance of knowing the alert. And then later on, we'll be calculating the alert. So this includes companionship, pain relief, oral fluids, woman's comfort to be mobile during labor. The third section is about the care of the babe. Okay, this includes the basal fetal heart rate. So if you've got only a pinard, it's fine, it's fine. But you must monitor for 1 full minute during and after a contraction. You look out if you've got an electronic fetal monitoring, the CTG machine, you look out for D cells, look at the amniotic fluid, look at the fetal position, caput and molding. Now look at the alerts there, okay? The alerts, they have said that if the baseline fetal heart rate is less than 110, it's an alert. See, for example, what do we do if it's 90? We write it as 90 and you'll have to circle it, whichever time that you see it, okay? If it is more than 160, it's a TAC. So even that is an alert, you have to. If you've got an early or a variable deceleration, it's not an alert. But if you've got a late decel, it's an alert. So you mark L and alert it. If it's an E, it's not an alert. You don't have to circle. Alert meaning you have to circle it. Okay. Amniotic fluid, if it is clear, it is C, it's intact, it's I, you know all that. But if it is a meconium stain and not a mild meconium, not 1 and 2 plus, but if it's a 3 plus, it's an alert. And if it's a bloody meconium, it's an alert. If so, if it is bloody, you write B and you circle it. Then we know we have to take a plan. Then fetal position. If it's an anterior position, it's fine. But if it's posterior or transverse, it's an alert. Okay. Caput 1+ caput is fine. 2+ is fine. But if it's 3+, it's an alert. So you'll have to put 3+ and circle it whenever the time is. Okay. And the molding 1+ and 2+ is not an alert, but 3+ is an alert. So I hope I've made myself very clear. So you take and write it down, and only if it comes under these variables which come under the alert column alone should be circled. Okay. Later on, we'll be seeing the number of circles. Then you look at section 4. You take the pulse of the patient. If it is less than 60, it's an alert. More than 120, it's an alert. The systolic BP is low, it's bad. So we know it's bad. Less than 80, more than 140. Okay. A diastolic BP only more than 90 is an alert. The temperature is hypothermia or hyperthermia, it's an alert. And urine, it is a persistent 2+ dipstick. Okay, 2+ dipstick, 1+ is not given an alert, and acetone, of course. So all that you have to take and mark it in your box the time that you see it, and then you must circle it if it comes under the alert category. Now, this is a very controversial column. Okay. But believe me when I tell you that this time limit given in this column has been an evidence-based time management. And they have said that evidence-based management, see, each centimeter has been calculated seeing the 95th centile of labor progress in women who have had normal perinatal outcome. So we cannot say no to this. I guess this would happen if the patient isn't got into spontaneous labor without any augmenting agents, it would have been like this. So now let's look at it. If the contractions are less than 2, you write 2 and then you must circle it. If it's more than 5, again, it's high tachysystole, you will have to circle it. Okay, the duration of the contraction is less than 20, you circle it, but probably the action you will be taking is to give oxytocin. You understand? If it's more than 60, you may have to give a tocolytic. So those are all the plans which you'll see in the 7th column. Okay. Now, when you look at the cervical dilatation, we'll start from below. If it at 5 centimeters, she can be even up to 6 hours. It really doesn't matter. As long as there is no other alerts, you understand? You'll have to look at everything before you take your management. 6 centimeters up to 5 hours is accepted as normal. 7 centimeters up to 3 hours. 8 centimeters up to 2.5 hours. Yes.
Shall I interrupt?
Yeah,
This 5 centimeter more than 6 hours alert, and 6 centimeter more than 5 hours. What does it mean? Actually, there's a confusion there.
No, there is. You know what actually it means? I told you in the beginning of the thing. After 5 centimeters, the total duration of labor in a primary should end by 12 hours. So these are all. So don't have to take. You can take some action if you find that it is lasting long, and if you find it is.
My doubt is this 5 centimeter, it should not go more than 6 hours. Then 6 centimeter more than 5 hours means after starting.
It is not like that. It forms an alert, ma'am.
Yes,
so you will have to take the action.
5 hours is meant from what? From the beginning.
No. 5 is from 5. 6 hours is from 5 centimeters.
Okay.
It's only an alert.
6 centimeters, again 5 hours.
Yeah. So if it takes longer than that, then it's an alert. So we don't have to take up. That is the end point. This they have calculated as a 95th centile of labor progress. You understand?
From 5 to 6, she can take 5 hours.
No, it is not exactly. That's an alert actually.
Yes.
You understand?
Less than 5 she can take.
Yeah.
That is a long time, no? That is what I have been thinking.
Give it a little
I've been
time.
thinking about this since this came.
Yeah, I've been thinking more than you, ma'am. I've been thinking more than you. See, at 9 centimeters, you can wait even up to about 2 hours for it to forget about the 5 and the 6. When you come, as you go up, see the time duration starts reducing. But look at the 2 columns above that. The contractions per 10 minutes are also there, and the duration. If you find it is less, you can augment with oxytocin. But if it is not required, they've asked you not. If it is not an alert, don't augment. You understand? And then they say that the second stage will never be more than 3 hours. We all know 1 hour for a multi, 2 hours for a primary. With epidural, 2 hours for a multi, 3 hours for a primary. So it never comes to more than 3 hours. But when, the most important time is not when she's fully dilated, but when she starts pushing, the push. So that is the time when they say the uteroplacental circulation can get compromised, and you don't allow that to become very long. So these are all, and look at that, the descent of the head is still marked per abdomen. 5 by 5, 4 by 5, 3 by 5, 2 by 5, 1 by 5 is engaged. If no pole is felt, that means it is a deeply engaged head. Okay. So this includes regular observation of frequency and duration of contraction, cervical dilatation, descent of the head. X is for cervical dilatation and P is for pushing, and 0 is marked to indicate the descent of the head. Then 6, of course, you all know the medication, whatever you're giving, oxytocin or what is that? Tocolytics or whatever, any medicines, any antibiotics, any IV fluids, anything, all that has got to be written on that. And this is the most important, the shared decision making. So I guess, it follows under 4 particular criteria. First, they say you have to assess the patient. Okay. Then you must record. Whatever you see, you record. Then you do a check. Does it come under the alert? If it's an alert, you put a circle around it. And then you take your plan of action. And that decision that you take, you've got to talk to the patient or with a bystander, and then you come to a decision. Many times, don't we tell our patient, see, you've been like this from morning, we don't see any progress of labor, we find that you're going, we have given you the maximum number of contractions that the patient can tolerate, we've given you the epidural, still you're not progressing, so don't you think it's better to do a section? So these are what they want you to do. They want you to facilitate a continuous communication with a woman and a companion, recording all the assessments and plans, and very importantly, they say you must talk to them in very simple language. And in a language which she understands, not in technical terms, and take a shared decision making. So in summary, as I said, the LCG provides care throughout labor and birth, and respectful maternity care, very important, effective communication, companionship, and continuity of care. And as I told you all, this labor care guide has got, first you assess the woman and her babe, you assess all the parameters, you mark everything. That's a recording. Then is a check to see whether it falls in the alert column, and then a plan. Now, very importantly, if we have what we are doing now, like I can say from Kerala, where we are going in for delivery at convenient hours, etc., this will not be really very practical, because we are actually augmenting them with doing the pre-cervical ripening with a mechanical, and then prostaglandins, and see, all that does not come under. This is all normal labor. They get into spontaneous labor. You can actually wait like this, and it really doesn't matter. To answer President Madams. So thank you, friends. Before I conclude, I just wanted to invite you all for focus, all the postgraduates who are out there. Focus is between August 26th and 30th of this year, the last week of August. And you need just make a note of the website. It is PG program, pgprogfocus.com. If you enter that, you will see the entire program has been put up, and you can register there. Welcome all the PGs to this session.
Thank you so much, Madam.
Thank you.
I request Dr. Prasanna Kumari, Madam, to kindly conclude the session.
Thank you, Dr. Serena. As usual, it was wonderful, explicit, and very lovely. Actually, this labor care guide, actually, this is not exactly, I wished that we all should have years back, when I used to be taking duty in the two most busy medical colleges of Kerala, Trivandrum and Calicut. We see patients crying, and nobody is giving her attention, and she is crying helpless. Actually, this WHO should have come forth with this type of a labor management, where the patient is given maximum importance. They should have come out with this type of management much earlier. Much earlier. And this can be practiced in all the levels of care in all the countries. And nowadays in Kerala, all of them prefer to have as Dr. Sarina said, an elective delivery. But I am personally very much against that.
Correct.
I think labor and delivery are natural processes.
Correct.
And women should deliver as I delivered. I started my pain at 6 p.m. and delivered at 9 p.m. And
Okay.
then at the antenatal PV, I was 3 centimeters dilated, both deliveries.
Okay.
And my daughter also delivered without any intervention. She
But did
went
you get any epidural, ma'am?
epidural, I gave to my daughter. I didn't get epidural. I didn't get any pain relief. I thought next pain will be very severe. So I was waiting for the next pain. And by the time the next pain I assessed, no, then it was time for delivery. I just delivered.
Okay.
And then only I had the birthday. So, and even in our center, I am trying my level best to avoid these interventions, and especially catheter, IV cannula, CTG. Even the normal patient will have a continuous CTG. I will tell them that you are tying the patient to the cord with the CTG and catheter and cannula. I am against it. I usually scold them for doing all this. And we usually, when the postgraduates come, we usually make them present this labor care guide, and we make them take class for the labor room sisters, labor room nurses. I'm strongly against all this. I'm strongly against induction, unnecessary induction. If you think you can do better, either for the baby or for the mother, you have to induce.
Ma'am, excuse me, can I say one word, ma'am? I feel that unnecessary inductions are responsible for the high cesarean rates.
Definitely. And high cesarean rate, placenta previa ingrita. So,
Yes.
And usual obstetrician may not be able to tackle that problem also. So I think all of us should practice this labor. My plea to the juniors is to practice this labor care guide and don't unnecessary induce. And as Dr. Serena said, the patient should be with the relatives till she is in active labor. So I also tell them, I send a labor room patient to the ward, go take a bath, have fluids, oral fluids, and chat with your husband and parents, and come back when you have severe pain. So I usually send them to labor, to the ward. So that should be the practice. So my plea to the juniors starting practice is to follow the labor care guides and induce. We have means of monitoring the baby. We have ultrasound, we have CTG, and we can ask the mother to count the fetal movements, exactly concentrating on the fetal movements. Say about 1 hour after breakfast, 1 hour after lunch, 1 hour after dinner. See, if you can carefully monitor, you will not miss, and you will not have an IUD. So that I can assure. You have means to know what is happening to the baby. You can see do an ultrasound, IUGR, see Doppler, CTG, and you decide when to interfere if she needs. Otherwise, the patient should start labor spontaneously and deliver. And this labor care guide should be followed by all the juniors practicing. That is my plea. Thank you.
Thank you so much, Madam Serena Girvas, for your excellent deliberation. And we're really thankful to you for taking up this topic, because as Madam has said, Madam Prasanna Kumari, thank you so much for sharing your views and experience also. In fact, watchful expectancy and masterly inactivity, initially good old days, and then came the active management of labor, all those protocols followed. And now again, we are going back to, watchful expectancy and masterly inactivity. Vigilant monitoring is the key to success, as you have rightly said. Thank you so much, Madam, for your expert comments as well. I think I can see one comment that please explain section 5 with an example that some Dr. Renu Jain has asked. Madam Serena, if you can please just highlight.
Okay. Now, can I tell you that this is based on the thing that everybody gets into spontaneous labor. It is not the induced ones which we are doing. That's why we find it so difficult to understand. So if you find that the patient comes under the alert, that means she's taking a long time at 5 centimeters, check out to see the other problems. See whether any other alerts are there. So you see all the circled ones in that 1 hour of decision making, whichever time that is, and then you take your call. Okay. Now, if on the contrary, if you find that she's 5 centimeters and it's a very idiomatic cervix and the cervix is not applied to the head, then there is a CPD. You understand? So you'll have to put everything. Don't go just blindly by the fact. They are just saying that if the patient is not augmented by in any other route, and if you take a normal labor, the patient can go in through this. It is not that she should be 6 hours in 5 centimeters, 5 hours at 6 centimeters, and then she'll go endlessly. That is not the way. See whether it comes under any one of these alerts. You understand? And then you take your call. Putting all the other parameters, everything should be your decision making.
So we have to use clinical judgments. Clinical judgment should be used.
Exactly. Exactly.
I wish Dr. Sneha Buyar all the best for the elections.
Thank you so much, madam. Thank you so much for all your blessings and your expert comments. I'm sure your experience has definitely stimulated the younger generations, to look forward for the spontaneous onset of labor, and of course to follow the labor care guide. Thank you so much, Madam Serena, as well.
Thank you. Thank you. Thank you so much.
So,
Thank you, madam. Yeah, we'll move on to the third session, our panel discussion on labor emergencies. As moderator, we have Dr. Sneha Buyar, madam, the AMOGS chairperson of Emergency Obstetric Committee. And as panelist, we have Dr. Kala Pramod, Professor, GMC Medical College, Trivandrum, Dr. Riti Rajan, Assistant Professor, Government Medical College, Trivandrum, Dr. Nimisha, Consultant, Mercy Hospital, Adur, Dr. Reena NR, Consultant, Obs and Gynae, Kollam, Dr. Deepthi PS, Assistant Professor, TD Medical College, Alapura, and Dr. Nurul Amin, Associate Professor, Government Medical College, Kottayam. On to you, ma'am.
So, thank you so much, Dr. Atulya, for introducing the panelists, and I welcome all the esteemed panelists here. Of course, the panel discussion is going to be very, very practical, as we have already discussed that it should be, spontaneous extempore answers from your side also, what is the way of you are practicing in your own practice. So I welcome Dr. Kala, Dr. Riti Rajan, Dr. Nimisha, Dr. Reena, Dr. Deepthi, and Dr. Nurul. And friends, without much ado, we straightway go to our presentation. So friends, all of you know, childbirth is actually a sentinel event in the woman's life, and of course her family as well. Everybody is so stressed up. Birth is intensely emotional and intensely physical as well. It is not 1, 2, 3 and the baby is out and everything is happy as it is shown in the movies. The aim of labor, all of us know that it should be a healthy baby from a healthy mother, and it should be a emotionally fulfilling experience for everybody, I would say. Whether we are the trainee obstetrician or maybe with huge experience of 30 years or so, every woman in labor, of course, especially as you say, the definitions are changing, the criteria for the stages of labor are changing. It is a challenge to manage, especially the second stage of labor. So we start with the first case now. We have this Gravida 5 para 4, all living 4 issues, delivered by Dai at home. Placenta is also removed at home, and she is brought to the labor ward with profuse bleeding. Where her vitals are, pulse rate is 120, BP is only 90 by 50 millimeter of mercury. So what is your provisional diagnosis from this clinical history and clinical examination? Can we start with the first panelist, please? Yes. Dr. Kala.
Okay, so madam, yeah, since she's a this can be a case of atonic BPH. Because she delivered at home and the placenta will separate the bleeding. And from this examination findings which you have given,
so I would just interrupt you here. From the history and clinical examinations, we are only getting the picture that she is having postpartum hemorrhage. There's no mention on the tone of uterus, right? So our clinical diagnosis only is postpartum hemorrhage. Now, when you get these findings, perabdominally the fundus of uterus or uterus per se is not filled. There's lots of bleeding here. You have this large fleshy mass, and of course, she's lying in the pool of blood. Large fleshy mass in the vagina, and cervical rim is not filled. So, what is your diagnosis now, Dr. Kala?
So from this examination findings, it seems like an acute inversion of the uterus, which is a
Right.
very rare emergency, but an immediate diagnosis and management is very vital. Although this condition is rare, I haven't, throughout this life, I haven't seen, there are many seniors sitting here who might have seen, I have got experiences from our labor room regarding an acute inversion.
Let me interrupt you here. I'm sure you must have not witnessed this at the vaginal delivery, but sometimes when you are doing, placenta, you are separating at the cesarean section.
Yes, yes.
Sometimes you find that, when you're trying to just give little traction, the fundus is coming along, and quickly you make out that yes, it's a fundus that is getting out. So you immediately leave that pull and try to repose, and then slowly when the placenta separates, you go ahead. I'm sure you must have experienced it, correct? Okay, so now you tell me that how do you manage this patient? What are the ways to manage this patient?
So as I've already told, the immediate diagnosis and immediate management is very, very important in this situation, because any delay can even produce this is one is life-threatening condition which we can lose the woman. So once you have diagnosis, the diagnosis mainly when you feel that this mass is protruding, and especially in per-abdominal examination, you won't be able to palpate the fundus of the uterus because it is inverted inside, and the patient will be in shock. And it is said that irrespective of, there will be bleeding, but the shock will be disproportionate to the amount of hemorrhage, because it can be a neurogenic shock also because of the traction on the nerves.
Yeah,
so
that's the very reason. How do you go ahead with the management?
So the first thing is you have to stop the uterotonics immediately, because it will produce a constriction ring. So that has to be stopped, and you have to alert your anesthetist and the theatre team, because if the manual reduction fails, immediately you have to go for a surgical intervention. So these people have to be alerted. And as in any emergencies, you start IV fluids, IV lines till the blood products come. And the immediate resort you have to try is a manual replacement, because once it is delayed, the constriction ring will be formed and it will be difficult. And you try the manual replacement by putting your hand inside, by trying to put the fundus back in the normal position by pushing it upwards. And if it fails,
so how do you do that? How do you do that? Because
while we are doing the procedure, the first thing is that make sure that first the region near that constriction ring, sometimes a small constriction ring might have been formed. So that region has to be pushed first, and then the rest of the uterus will go, because otherwise we have to push in a very larger diameters has to be pushed. So the region that is close to the constriction ring should be pushed inside first. And if it fails, immediately you rush the patient to the OT, because the anesthetist, if it is available, he can help.
Let us talk to the talk about the simpler thing first. As you have said, manual reposition. So is it the part which is larger, so you want to push the cervix first, or is there something else? Because that is a part which is coming last. So that has to be pushed first, because that is closest to the ring, cervical, right? Yeah. So naturally you have to push it in a reverse way. The way it has come, we have to push it in a reverse way. Okay, then what do you do once you push it? Then what do you do?
Once you push inside, immediately you can restart your uterotonics, because you have stopped it just for the reduction. You restart, make the uterus contract, and make one important thing you have to make sure is don't try to separate the placenta before manual reduction, because it will aggravate the bleeding. Only after manual reduction, you can try removal of the placenta.
Agreed. Now, once you have reposed the uterus, do you want to keep your hand for some time inside?
Yes, madam.
Stabilize. Yes. So what are all those precautions? That also you need to explain. Okay, you have to keep the hand inside for some time. You have to stabilize the uterus with your left hand, and then you start your uterotonics. How long you should continue this uterotonics?
Uterotonics till the uterus is contracted, very much contracted. You have to continue the uterotonics.
What do you think is the time? Because sometimes you can get even the primary again you can get the recurrence of the tonicity of the uterus. That may be the cause of the inversion, right? So at least a uterotonics for 8 to 12 hours, 12 hours of uterus. Okay, then what else? If at all your manual, see here, it is shown in this picture. You keep your fist inside. Once you put with your left hand, you stabilize, and then of course you continue the uterotonics. Correct? So at least for 8 to 12 hours. Now, if at all it fails, then is there any other method, conservative, non-surgical methods?
Yes, madam. If there are no facilities for an immediate surgical intervention, this one also you can try. That is a hydrostatic reduction. Here you can make the patient in a reverse Trendelenburg position, deep Trendelenburg position, and you can hang a IV fluid about 1 meter above the patient, and fluid is instilled into the vagina. Previously, we were told that we can close the vagina with our hands. Now the certain books say that we can put this vacuum cup, elastic vacuum cup inside, and through the nozzle we can instill the fluid so that there won't be much leak outside, so that the mass get reduced. So that is called a hydrostatic reduction. About 2 to 5 liters of fluid we can instill so that this get manually corrected. But this is a situation where there is no facilities for an immediate surgical intervention. So such conditions we can try this.
Yeah, so by the time your OT and anesthetist things are getting ready, maybe you can try this. So because manual reduction or hydrostatic pressure, this approach fails, then what is the other option, the surgical approach? Dr. Rithi, this is for you. You can take
Yes, madam. I think in around 90% of cases, the manual reduction will be successful. So only 3 to 10% of patients will need a surgical approach.
Yes, but if I tell you that this patient has delivered at home by DIE, and maybe she has traveled some distance. Yeah, so
when there is a delay, when there is a delay, the uterine fundus becomes edematous and the constriction ring forms. So there is a chance that the manual reduction may not be successful. So the decision for surgery should not be delayed because the shock resolves only when the uterus is reduced back. And vaginal approach is actually not recommended anymore. So we have to go for a laparotomy, an abdominal approach. So during surgery, we can see the dimple of the uterus, uterine fundus where it should have been. We can see the ovarian ligaments and the round ligaments going into the dimple. And so we can try initially, we can just dip your hand into the pelvis and try to reach below the fundus of the uterus and gradually pull up the uterus so that the inversion may be reduced. So if that is not successful, another simple way is you can use a elastic cup over the dimple and apply negative pressure so that the fundus of the uterus can be sucked out. And another way is a Huntington's operation. This is the classical approach whereby you can use an Alice forceps or a sponge folding forceps to ligament and gently apply upward traction so that the fundus of the uterus is taken out, and then you have to remove and reapply deeper inside till the uterus is totally out, the fundus is totally out. And sometimes when the constriction ring is actually very tight, you may not be able to take out the fundus easily. Then you have to cut the constriction ring posteriorly and then do the same procedure, taking out, giving traction on the round ligaments. It's called the Halting's procedure. And following that, you have to repair the cut that you made.
Yes.
And always you have to remember that once you reposition the uterus will be very atonic. So you have to start uterotonics immediately to prevent postpartum hemorrhage. And also a broad spectrum antibiotics because there is a chance for puerperal sepsis.
Correct. So you have discussed this very nicely. Only one step in between the cutting the constriction ring or the cervical ring. Maybe under anesthesia, you can try and stretch the cervical ring, and if then it allows to just to repose the uterus or the uterine fundus, that should be tried. That is one. And secondly, this is what is described, Halton's procedure. These are the other methods what you discussed about the vacuum cup and of course the balloon of the Foley's catheter also. There are certain other methods like Spigne's and Kushner's methods. Okay, so these
the anterior colpotomy is not done because there is a chance for bladder injury.
Correct. So these are not very frequently practiced, and as somebody has said, this is not a very common happening, though we, as a vaginal delivery, because all of us are now well aware of what. So let me ask you, in other words, what are the reasons for this happening? Yeah. Why it should happen, the uterine inversion during...
It's an improper management of the third stage of labor. If you perform an active management properly, it should not happen. It's preventable.
That is one. But otherwise, suppose the obstetrician is good obstetrician, managing very well, following the brand entrance technique, everything. But otherwise, what is the inherent default with this?
Sometimes, madam, in adherent placenta or sometimes in the prolonged labor, when the uterus is atonic, and at the time when you are giving traction, this can happen.
Yes, definitely. So if it is a very short cord fundal, fundal implantation, attachment of the placenta, and then of course it is a adherent placenta. Maybe the uterus is too atonic, right? So these are all the reasons, and these you have to see to it that you don't land up into uterine inversion. Before that, you correct all these things, and then of course. If at all you have such a patient, you need not be in hesitation to go ahead with surgery, because failure of surgery, all these things will lead to gangrene, and it will result into hysterectomy if at all it is delayed further. So postoperatively, Dr. Rithi has already talked about the uterotonics for 8 to 12 hours, the prophylactic antibiotics, and then of course if the atonicity is there, then you have to go other oxytocics like the what you call it as prostaglandins, yes, alpha, or what you call it as carbopros. Okay, so and maybe even the misoprostol tablet 600 to 800 milligram you can use. So all this has to be taken, even though this is a rare condition. This is a life-threatening condition. If at all it happens to you, you should be able to manage then and there only. And that's the reason we have included this case. So thank you so much, Dr. Kala and Dr. Rithi, for wonderful discussion. We now go ahead with the second case. Dr. Reena, this is for you. Do we have Dr. Reena here? Yes, yes. So Dr. Reena, 37 weeks primary, she comes to you in labor. Vitals are good, and she's got mild contractions, 25 seconds every 4 minutes. Head is floating, her fetal heart is good. So she's in early labor, but you find that suddenly you are monitoring her properly. Suddenly there is a fetal heart rate drop. So what is the diagnosis here, and how will you confirm the diagnosis? How will you manage this case?
Okay, ma'am. And the probable diagnosis by this description is a cord prolapse, umbilical cord prolapse. And by doing simple pervaginal examination, we can confirm the diagnosis. And
what event has happened in between that has led to this complication?
It is a leaking, PROM.
Yes, spontaneous.
Not PROM, rupture of membrane.
Right. Okay. So now you will examine this patient. You will do her pulse speculum examination. You find there is a frank leaking, and when you do internal examination, the pervaginal examination, you find that there is a cord. So cord prolapse. Now, what actions how will you manage this patient?
First and foremost, we have to decompress the cord by disengaging the presenting part. So manually lift the presenting part and also position the patient, position the mother. And do modified Sims position, that is exaggerated Sims position, that is left lateral position with head down by placing a pillow under the left buttock.
Okay.
And also evaluate, tube evaluation and tube delivery is the norm.
Yeah, but then how will you manage? That's what, how do you go ahead?
If it is fully dilated, and when vaginal delivery is very, if you feel that vaginal delivery is very easy, we can go in for vaginal delivery. Even in full dilatation, we have to do LSCS in these type of cases.
Yeah, so basically
and we have to disengage the presenting part by filling the bladder. And lifting the presenting part by manually lifting the presenting part.
Okay. Okay. Anybody wants to add anything to this? What Madam has said?
Yeah, here it's a cord prolapse. It's a case. So we have to emergency deliver the baby. We have to do crash cesarean to deliver the baby. That is category 1 says within 30 minutes we have to deliver the baby. And so while the meantime, you can, as Madam said, you can take the head low position or a knee chest position. Manually elevate the fetal head, but do not manipulate with the cord because vasospasm can occur. So do not manipulate. You can elevate the fetal head, and also you can fill the bladder and shift the patient to the theater, alert the anesthetist, and emergency cesarean and deliver the baby out.
Yes.
Also cover the cord with a dry mop so that the external stimulation can be avoided.
Yeah, supplementation of oxygen, any role?
Yes.
Yes.
No. Tocolysis is indicated.
Or you can give tocolytics if contractions are there. Terbutaline 250 microgram can be given.
Yes, but Dr. Dipti, as you just now you said that you have to go for a crash cesarean section. So
Yeah.
as far as possible, you have to take her for cesarean section, or maybe the principle of delivery is such that you have to deliver the baby as soon as possible by whatever modality. If you feel she is fully dilated, maybe with instrumental delivery, you can
Assisted
do that,
delivery,
right?
instrumental delivery can.
Right, right. If at all no, you have to take her up for cesarean section. I would say you arrange for the cesarean section at the earliest. As you said, you have to go ahead fast, right? But meanwhile, if there is some delay in the arrangement, then you have to do all these supplementary procedures, right?
So yes.
Right. So you have to go ahead with the cesarean section. We have talked about what are the reasons for this. But suppose now I have said that when you examine this patient, she has already, she has spontaneous rupture of membrane. She has fetal heart rate drop. But when you examine with your fingers per vaginal examination, you don't find the cord. Now what is it? Dr. Nimisha. Dr. Nimisha, I would like to listen to you. When you do her per vaginal examination, you don't feel the cord. We can't hear you, Dr. Nimisha. We can't hear you, my dear. I think your device volume is low, or maybe you have joined without the computer audio. No, we can't hear you at all. Is it right? Can all of you hear her? Yes, Dr. Kala? No. So either her device volume is very low that she has to increase, or she has to log out immediately, log in again, join with audio. Okay. Is it right? So somebody else can take up. Dr. Rithi, do you want to add something? That you have this same picture. You have a spontaneous rupture of membrane. You can see frankly, you do her PV, you don't find cord prolapse there.
If it's a case of polyhydramnios, we can suspect abruption. It will be without rupture of membrane. If there is a sudden drop in fetal heart rate, should suspect abruption.
No, I'm telling you, there is a spontaneous rupture of membranes. When you find that, yes, there is a rupture of membranes, there is a fetal distress, there is no bleeding, but you don't feel the cord. That is called as occult cord prolapse only. But you don't feel the cord because the cord is not lying into the introitus or outside the introitus or maybe in the cervix. It is lying somewhere, it has descended along the side of the presenting part and it is getting compressed in between the uterus and the presenting part, right?
Okay.
So it is an occult cord prolapse.
Presentation.
Okay. So this is what, because of all these conditions, it can happen. This is what I have given you the predisposing factors and then how to avoid the aggravating factors, right? So this is what we have discussed, that it is a occult cord prolapse. Sometimes you find that, suppose this patient has come to you before labor and you do her ultrasonography and you find that there is a maybe as Dr. Dipti is saying, now we can take up this way that there is a the fetal heart rate is normal initially. Now there is a sudden drop that has happened because of the cord prolapse, maybe frank or the occult. But when sometimes you just monitor the patient's labor, there is no fetal heart rate dip, and when you examine, you find that there's pulsations of the cord. The membranes are still intact. What is this condition now?
A cord presentation with intact membranes. The cord is felt. It's a cord presentation.
Cord presentation. So, Dr. Nimisha, are you able to speak? Can you try? Hello? No. No. We can't hear you. I told you, you just log out for a moment and join again with computer audio. Okay. Saiti, if you can guide her, please. So this is cord presentation. So suppose you diagnose cord presentation at or near term. What are the guidelines and what you should do with this patient? If not, Dr. Nimisha, we can go ahead once again, Dr. Kala and then Dr. Rithi.
if it's a cord presentation, you have diagnosed, definitely you have to go for a cesarean section. Not a crash cesarean, but you have to immediately you have to go decide on a cesarean section, madam. Cord presentation. Because if the membranes rupture, she will inherently land in a cord prolapse.
Correct. So if she is near term and you find that on ultrasound, you find that there is a cord presentation and she is in near future going into labor, don't allow her to go into labor. Of course, absolute no-no for induction of labor and absolute no-no for the artificial rupture of membranes, right? So you have to go for elective cesarean section if you diagnose cord presentation near term. Now, I would just ask you, what are the guidelines to avoid all these complications? Dr. Dipti.
To avoid cord presentation or cord prolapse, madam?
Cord prolapse. Cord prolapse.
Prolapse. So in case of early patient coming with labor and the head is high floating, never attempt early rupture of membranes. Should avoid rupturing of membranes.
Right.
And also in case of breech presentations or transverse lie also, should carefully monitor the CTG and look for the fetal heart decelerations, whether it is occurring or not.
Right. So according to RCOG Green Top guidelines also, you have to make out the abnormal lie, abnormal presentations at around 36 to 37 weeks. You have to identify, label them, and of course you have to keep a very stringent watch on these patients. You have to tell them, warn them, identify them, and you have to tell them that these patients should not go into spontaneous labor. According to RCOG guidelines, you have to give them an option for the external cephalic versions if at all it's a transverse lie or a breech. That is what is recommended. But if at all you find that it is either she declines the ECV or it fails, then of course you have to give her informed choice for the elective cesarean section. That is what is the recommendation. And of course, ARM should be avoided, and you don't have to allow her even for spontaneous labor and spontaneous rupture of membranes. So that is what are the Green Top guidelines. ACOG also says that early identification of these patients at risk and early detection of cord presentation definitely should try to avoid the cord prolapse. And of course, if at all you diagnose or identify, you have to recognize at the earliest and prompt treatment, delivery of the baby by whatever modalities at the earliest. So that is all about the cord prolapse. We are having interesting short crisp cases, and I'm happy that we are getting good take-home messages. So over to you, Dr. Nurul Amin, for this third case now. We have this 28-year-old fourth gravida who has had 3 spontaneous abortions. Now 39 weeks she's in labor, and she delivers a full-term baby girl. Placenta is not expelled for around 45 minutes. So what is your diagnosis and how do you go ahead with the management?
This case, we have a diagnosis of a retained placenta or a prolonged third stage. So by definition, it's because she has already been 45 minutes. Any third stage which crosses 30 minutes with an active management of labor. And if you're not done active management, then you can wait for 60 minutes. But usually all of us practice an active management. But in this scenario, we can take it as a case of a retained placenta because we usually expect the placenta to expel by an average of 15-20 minutes.
Right. So what are your steps to be taken for this?
Now the patient has come like this. We have to find out the cause why she has had a retained placenta. Major things are 3 important things you have to rule out. First is whether it is a separated placenta and then it has been trapped or incarcerated. 2 is whether the placenta has not been expelled, not separated, it is still attached, but it is normal adherence. The third thing is when you have a morbidly adherent placenta, where the placenta is invaded into the myometrium and beyond.
Right. So how do you do this? How do you know this?
Yeah, first thing you have to do is if you have to first see if clinically you have to see if the patient has shown any signs of a placental separation. So the signs of placental separation being if you find that there is a gush of blood, there is a apparent lengthening of the umbilical cord. When you see the uterus has become more contracted and globular and the height has slightly ascended, and then you find a bulge in the suprapubic area. Then we the best thing is to just put your hand vaginally and see if the placenta is felt anywhere outside the cervix or inside the cervix with the os closed. So that is how you diagnose the first scenario. The second scenario is when you find.
Suppose, Dr. Nurul, we have this patient whose placenta is not expelled for 45 minutes. She has come to you. There's absolutely no bleeding and there are no signs of separation.
So in this case, again, a placenta which is separated can show bleeding. In this patient, it can either be an adherent placenta or the most worst scenario would be you may be dealing with a case of a morbidly adherent placenta. One more thing to think about is this patient has had 3 abortions.
That is what I'm asking you. How do you make out this?
So we have to take a good history from the patient about her previous 3 abortions and see if there was a DNC or the curettage that was done during those times that can be a precipitating factor for a what you call a morbidly adherent placenta.
Yes, yes.
So
but
that's
even
one.
if you don't have this history, suppose, and she has this situation and there is no signs of separations, would you not go for ultrasound?
Ultrasound, yes, ma'am.
Yes.
Yes. With the availability of ultrasound widely now, we can go for an ultrasound and look for any features of a morbid adherent placenta.
Okay.
Then,
by the time, would you like to do something for this patient? Once you suppose you see put in a probe, you find that there is no adherence. Now, what would you like to?
So the major cause of a situation where the placenta has not separated, but it is not morbidly adherent, it doesn't look like that, then it is the uterine contraction that you have to look for. So you have to make the uterus contract one. So you should give good oxytocin, and also you can try active management. That is, you can do a contraction with a countertraction and see if you can pull out the placenta and separate it.
One simple measure I would say that I'm sure you must be also doing. You have to catheterize the bladder or ask her to empty the bladder, because sometimes full bladder can also lead to atony. So if once you empty the bladder and then once you're sure that it is not morbidly adherent, you will start with the oxytocin definitely. And then, of course, you will try for the, Brand Andrews or the controlled cord traction. Of course, with your anesthetist standing by your side, correct?
Yes.
If you separate it, well and good. If no, then what would you do?
So if you're talking about if the patient is having a morbidly adherent placenta, or
no, it is not. That is why we are going ahead.
Okay. Now we have to do a plan for a manual removal of the placenta. So a manual removal of placenta in today's time is better to be done in an operation theater with all the facilities. When you have only in a dire emergency, when we don't have all these things, then we can attempt one in the labor room. So it's better to shift the patient to the theater, take the time, as long as she's not bleeding much and she's her vitals are stable, then you can give her some more time, more than 30 minutes. You can wait for 60 minutes, and then we can plan for a surgical removal of the placenta. So in the surgical removal, you have to take her to the theater, give her an anesthesia, tell the anesthetist that you want dilatation of the cervix. So he or she can give drugs which will help you there. And then we can go in the classical method where you use the hand in a cone method, and then go inside, tracking along the umbilical cord. So till you reach the attachment of the cord, then slowly come back to the border between the placenta and the uterus, and then you start slowly separating the placenta by sweeping movements.
Right. So
then give oxytocin once you have separated the placenta and the placenta is out.
Take the placenta all around first, and then you turn it and remove it with the same hand, right?
Yes, ma'am.
And then you give, of course, once you separate the placenta, immediately you have to give uterotonics, and you have to continue your hand to be kept inside for some time, and then, of course, give bimanual compression. I would say not massage here, definitely. But once you remove the placenta, you deliver the placenta. Now what you do with the placenta? You have to inspect.
You should first check for the completeness of the placenta, if there are any cotyledons missing. So take it in the palm of your hand and check if there is any missing cotyledons. If the missing cotyledons are there, then you should suspect a retained bits of placenta. You should go for ultrasound scan. You should give her antibiotics, and you should plan for.
So which aspect of placenta you want to inspect? Whether it is maternal or fetal aspect?
Pardon me, ma'am?
Which aspect, which surface of the placenta you want to inspect, or
the
both?
maternal surface.
the maternal surface for the remaining cottage.
Yes.
But suppose if she has some subcensurate lobe of placenta,
Yes.
maybe.
Yes. We
then
can
you
also look
yeah.
for fetal surface, right?
Right. So that is how you have to inspect both the aspects of the placenta, and then you continue with your management, whatever you have discussed. Correct? So you have to separate, expel, and then you have to continue the oxytocin. Of course, give prophylactic antibiotics because you have already, did lots of manipulations here, and then you inspect the placenta, everything. Right. So that is how suppose this was a case of placenta accreta spectrum, how you would have proceeded further. She's, 3 spontaneous abortion, but para 1 only. This is the first delivery, right? Hello? Yes, Dr. Kala, I think Dr. Nurul
Madam, what's the question you asked?
This was a simple adherence of the placenta, right? So we could separate and remove. But suppose this was a morbidly adherent placenta, then what was the management? Then what is
so if the ultrasound, we have diagnosed a morbidly adherent placenta, ideally it should be diagnosed during the antenatal period itself. That is for all cases previous cesarean. If there is an anterior low-lying placenta, definitely you have to look for an adherent placenta in the antenatal scan. And if ultrasound.
But our patient doesn't have previous cesarean section, but she has 3 abortions previously. Maybe she has had D&E or maybe the check curettage at least. Okay, so it may not be anterior, it can be posterior placenta also, correct?
Yeah.
Yeah.
So if you have diagnosed it early, you should have planned the surgery accordingly. You have to plan a hysterectomy.
Yes, then we have not diagnosed. That is why this patient has landed up into retained placenta, and now we diagnose it as the morbidly adherent placenta or placenta accreta spectrum. How do you go ahead with the management? That is what the question is. Dr. Pala and Dr. Rithi, I think, can take up.
There are different options, madam.
Yes.
Some used to retain the placenta is left inside the remaining placenta. If there is no bleeding, there's an option of giving methotrexate. Some will can go for a operative intervention, laparotomy.
Depending on the degree of adherence, if it's a
evidence doesn't allow us to keep it inside. Okay, Dr. Prithi, yes, please go ahead. Your take on.
Madam, if it is you have to make out where the extent of the adherence, if it's a focal one or it is adherent increta or a percreta. So accordingly, you will need a senior help and from the obstetric as well as the anesthesia colleagues will have to counsel the bystanders, alert the blood bank for a massive transfusion protocol, and try to do a focal excision of the adherent part and conserve the uterus if possible. Otherwise,
I would ask you the other way around. Suppose this patient being only the first delivery or para 1, we would say, because we have to conserve her uterus because that is her wish. Also, they have not given you the consent for hysterectomy on priority. They have just subjected to, the possibility of conservative surgery. So if at all you have to conserve the uterus, what is the procedure that will allow you to conserve this uterus? Because
Triple P
try
procedure.
to remove it will bleed torrentially. The patient who was stable will become unstable.
You have to do a stepwise devascularization. We can go for an aortic clamp or an internal iliac ligation, a uterine ligation. And then,
Yes.
And then you can try to do a triple P procedure if possible.
Yes.
If everything fails, you will have to
Triple
go
P
for
procedure is one which you can plan, but for that, when you do the ultrasound, you have to map the placenta. What is the depth of invasion? Correct? And then you have to plan accordingly. So that is one is placental mapping. Second is stepwise pelvic devascularization, and third is patchy resection. That is what is the triple P, right? You were talking about aortic clamp. We are so proud to, talk about this clamp because this is Dr. V.P. Pailisar's clamp, and we are very fond of it. So can you throw some light on this? What is aortic clamp and how do you use that? How does it help it?
Aortic clamp is actually an atraumatic clamp, madam. It doesn't crush the vessel completely. So you actually expose the aorta just above the bifurcation of the aorta. You have to pack the bowels away properly. And then you have to you have to lift up the aorta with the Babcock and apply the aortic clamp over the aorta.
Yes, the
and leave it there.
entire lumen fits into this clamp like this. That is what.
Yes.
So,
And you have
introduce
to,
the blood supply.
yeah, to release it every 30 minutes or so and watch the clock. And it is very effective, madam. It reduces the blood loss.
Right. So that you have said it very rightly. The second procedure for conservative surgery for this is what is called as, it is called as the KFOG MG stitch. They they occlude the upper uterine vessels first, the above the uterine incision, if at all, because here in this case we have not taken any uterine incision, but suppose we have to occlude the upper uterine vessels first, and then also at the cervico-ischemic level, so the descending cervicals, at both the places you have to occlude. So first you have to go for selective pelvic stepwise pelvic devascularization, and then what is called as the patchy resection, not the triple P exactly, but you try to remove everything, scalp, you try to scratch it out. So that is what is also a uterine conservative procedure. This is called as KFOG MG, the Dr. Mahesh Gupta stitch. This is also a patented procedure. So a patented stitch, I would say, people are using it all across the world. So we should be proud of that also. Correct. So this is what is about the placenta accreta spectrum. Now we go ahead with the next case, and that is the breech. You have this second gravida paravan who has delivered normally vaginally previously. Now she comes to you with full-term pregnancy with strong labor pains, and she comes to you as emergency. When you examine her vitals are good, fetal heart is good, but she's got such a strong pains that she's actually pushing, and you do her internal examination. Cervix is fully dilated, fully effaced, and breech presentation station +1. So Dr. Kala, her pelvis is also adequate. How will you tackle this case? Whether you want to deliver her vaginally or you want to take her for cesarean section, and how do you decide that?
Since the patient is a second gravida and the breech with a very good pelvis according to you, and it is in +1, I may attempt a breech vaginal delivery, but before that I will actually counsel the patient and the bystanders, because from the referral hospital they might have counseled her for a cesarean section. So that counseling is important. I will also do an intrapartum ultrasound to see whether there is any cause for the breech presentation like a hydrocephalus, or whether there is hyperextension of the neck. And also also I will assess the station also by an intrapartum ultrasound. And after the counseling, if they are willing, we will be telling that the breech is actually in the perineum and there is a chance of vaginal delivery.
Not perineum, +1.
It is +1. Okay, it's in the +1. So definitely, if they are getting a consent for a vaginal delivery, we can keep her for a breech vaginal delivery. Make sure that they are a senior person who is very well versed in a breech vaginal delivery. Then the anesthetist, everything are in your place, so that you can safely conduct a breech vaginal delivery.
Sorry to interrupt you, Dr. Kala. Will you not give her any option for cesarean section?
If suppose I find that it's a footling breech, or I find that there is a hyperextended neck, in such cases, we can definitely take her for a cesarean section, madam.
Yeah, but otherwise also you have, previous delivery was a normal vaginal delivery. It was a cephalic presentation. But considering this breech, that is still +1. Will you not give her the option for?
No, if she's going to deliver, she has to deliver within a few time, because there are good uterine contractions and the breech is in +1. So
But
I won't give her a prolonged second stage. Up to maximum 30 minutes, the breech should be climbing the perineum and she should be able to conduct a breech delivery.
Yes.
Because in this situation.
Suppose, Dr. Kala, suppose she is trying to deliver, and suppose after coming it gets strapped and she lands up into problem. So will she not create problem for us?
So that is why I told no, madam, I will counsel the bystanders initially. Then only I will take her. Otherwise, I will definitely.
Maybe I will go a step ahead and say we will keep everything ready.
Yeah.
This section. That is a better way that we will keep everything ready, but we'll try to do it, deliver vaginally. If it's coming uneventfully, well and good. Otherwise, we go for cesarean section.
Yes.
Of course, yes. You will keep everything ready. As you said, somebody who is expert in breech delivery, breech vaginal delivery. Right. Now, suppose before, sometimes it can happen that, by the time your team is counseling the patient relatives and by the time you are assessing the patient, such patient can just throw that baby in your hand, right? So that's happy moment. But suppose she just pushes the breech at the perineum and then there is no progress. Then that is a problem. So how do you do assisted breech vaginal delivery?
So the most important principles during a breech vaginal delivery, if you are planning for an assisted breech delivery, it's about watchful expectancy on the part of the obstetrician because if the breech is going to deliver, it will come spontaneously almost up to the level of the umbilicus. Only in certain regions. And the two other important principles is never give traction from below and never give fundal or a push from above and never pull from below. These principles you have to definitely follow. And always we say that for other cephalic presentation episiotomy is not we are only for we are against routine episiotomy, but in the case of breech sometimes we have to put almost all the cases we have to put a very good episiotomy. And always try to conduct the delivery in the labor code with the patient at the edge of the delivery code. And the things you have to ensure is that the back of the baby should be facing the obstetrician while doing the way, and holding the baby in such a way so as to never press on the abdomen to avoid visceral injuries. It should be a femoropelvic grip. And then, as I told, when the umbilical cord is coming, you just feel the pulsation, keep it to one side, cover the baby, and till the delivery of the shoulders, we need not do much intervention, except in certain cases where the limbs may be extended. Such cases, we may have to resort to a Pinard's maneuver for delivery of the extended legs. And when it comes to the shoulders, you can see whether feel in front, the arms are in front of then there is no need for any other maneuver. But if you feel that the arms are hyperextended arms, sometimes you may have to resort to closed maneuver, but majority of the cases it may not be needed at all. The arms will come, if it's in the front, it will come out. And the only difficulty we may face is during the delivery of the aftercoming head. And there are so many techniques which are written, and also the best one is using a forceps because it can avoid undue traction on the neck of the baby. It will ensure a controlled delivery of the fetal head if you are applying a forceps.
Perfect. So before that, I would just want you to elaborate because, there are so many people who have joined. So what is this? You have, delivered the baby up to the scapula, and you have said that, yes, even the shoulders, you have delivered both the arms, but the aftercoming head is stuck up now. So what is this Burns-Marshall technique? How do you do that?
Yeah. Burns-Marshall technique is a usual technique that you can deliver. Here, by the assistant will be giving adequate support, and the person who is conducting the delivery has to catch hold of the foot of the baby in such a way, and then carry it over an arc over the mother's abdomen, and adequate support. The baby's head will be delivered in a controlled manner. But
so both the ankles you mean.
Yeah.
Right.
But far better is other method.
You have to catch hold of both the ankles. The assistant is supporting, but your other assistant is giving little suprapubic pressure.
Yeah, suprapubic pressure also. Crystal amino that has to be given. That is to promote the flexion of the fetal head, prevent the head from going extended. So that has to be given. Suprapubic pressure has to be given.
Right. If she doesn't deliver, you have just tried once. No, it's not coming. Then what will you do?
There is another method that many practice that is called the Maris's milliveight method. I feel it is more comfortable. You have to hold the baby. The baby has to lie on your hand in such a way, and the other hand will also go inside the vagina, and the hand on which the baby is lying, that will be pressing over the maxilla. That will be promoting the flexion. The other hand on the abdomen will be promoting the flexion, and you have to give traction like this and deliver. That is another method. That's called the Maris's.
Is it on the abdomen? Both the hands? Is it on the abdomen or?
No, madam. Both the hands are in the vagina.
That is what I'm saying. Yeah. So left hand you will hold the baby. Two fingers on the maxilla.
Over the maxilla.
Not in the mouth, but yes, under the chin.
That
the
will be
right hand,
promoting the flexion. And the other hand over the head, and it will be
Shoulders.
promoting the flexion like this.
Shoulders and the occiput, the middle one, right? Okay. So, Dr. Reena, whether you want to add something here, or we can.
It is malar flexion plus shoulder traction.
Yes, that is called as malar flexion with shoulder traction. That is why I was telling you that you have to keep it like this and flex the, you push the occiput and then you give the shoulder traction, right? And then, of course, what kind of forceps you can apply? How do you hold the baby for the after coming head? Yes.
For the forceps. So for the forceps, actually, you have to cover the baby with the towel and just hold the baby a little up, little above 90 degree. And then you can use a particular type of forceps called the Piper's forceps.
Yeah.
Or if it is not available, a usual outlet forceps with a smaller blade can also be used. And so after, then you can apply the forceps as in any other application of forceps. And the advantage of forceps is that, as I've already told, it won't give, there also no traction on the neck. And it promotes a controlled delivery of the head. So the chance of intracranial bleed, everything is minimized.
Yeah. So we go ahead with the now last case, I would say. This is as you have Dr. Rithi and Dr. Reena. I think both of you will discuss this case. We have this second gravida, 34-year-old lady. She's got gestational diabetes. She comes to you at 37 weeks in labor. You examine her that, 36 week size, cephalic presentation, 3-5 palpable, everything fine, 2 centimeters. She's a second gravida, so she progresses well. And, nicely she becomes fully dilated, fully effaced over maybe around 6 hours. So after 20 minutes of full dilatation, the head is delivered, but the baby is not descending down. So what is your diagnosis, Dr. Rithi? What is this?
This is a case of shoulder dystocia, madam.
Mm-hmm.
Shoulder dystocia is diagnosed when the head is delivered and routine axial traction on the head fails to deliver the shoulders and the body of the baby. In this case, the main problem is when you delay delivery beyond 5 minutes, the baby has a hypoxic brain damage. And also when you give undue downward traction on the head, there is a chance for a brachial plexus injury as well.
Okay.
So downward traction is an absolute no. Don't give a fundal pressure and ask the mother to stop straining as well.
Yeah.
And it is important that every staff in the labor ward is trained in the management of this condition. There should be regular drills so that everyone is well versed.
Yes.
And we can remember the management of shoulder dystocia by the mnemonic HELPER. So in HELPER, H stands for calling for help, which is the first step. You have to have the neonatologist, the supporting staff, senior obstetrician ready. E stands for episiotomy. You have to evaluate for episiotomy if you need space to manipulate into the vagina. Then L stands for your Macrobert's maneuver, which will tilt the pelvis so that the anteroposterior diameter of the pelvis is increased. That gives space for the shoulder to come in. And then you have your P, which is a suprapubic pressure, or the Rubin's maneuver, in which you have to put one hand over the other, like you give a CPR, and press on the shoulder posteriorly to flex the shoulder.
Yeah, Dr. Rithi, what is the position of the mother?
The mother has to be brought to the edge of the table and the legs has to be actually abducted and flexed onto the abdomen when you do a Macrobert's.
What is this maneuver called as?
Macrobert's.
Macrobert's. Right, right. So Dr.
That is
Reena,
true.
please go ahead, no worries.
Yeah, and then when you try every maneuver, you have to give 30 seconds time and don't unduly waste time. And then the next step after the Macrobert's, you can go in for the suprapubic pressure, whereby you try to flex the shoulder anteriorly so that the shoulder will rotate and get into the pelvis.
What
Then
do you
have
achieve with these maneuvers? What do you achieve? How does it help?
Basically, it is a bone-to-bone dystocia, madam, when the shoulders are stuck against the symphysis. So you're trying to rotate the shoulders to a wider oblique or transverse diameter so that the baby can be delivered easily. And always, all these maneuvers are possible only in a unilateral dystocia. When it is a bilateral dystocia, vaginal delivery is almost impossible. You have to resort to a cesarean section.
Yes. So basically, see this, when you do that Macrobert's maneuver, hyperflexion of her thighs on the abdomen, Then there is what is called as the increase in the anteroposterior diameter of the pelvis, and there's straightening of the pelvis as well. The birth canal is also straightened. That is one. Okay. So the capacity of the pelvis is increased. Secondly, I would ask you, where do you want to give the, you have to ask your assistant to give the suprapubic pressure. So which right, left, anterior, posterior, how do you decide where do you give the shoulder, suprapubic pressure?
That is given behind the anterior shoulder.
How do
where
you
the baby
know what
should?
is where is
That
that?
is where the occiput is, madam.
Right.
The side of the occiput gives
You
you
know
the
it, but we want our attendees to also understand, because you know nowadays you don't get to see all these conditions and people don't know how to manage it if at all they face it. You have to make sure that you know the shoulder which is on the side of the occiput.
Occiput,
Your
yes.
head is lying outside, so you can easily make out where is the occiput. So that sided shoulder you have to push it little anteriorly and towards medial side, medial aspect, so that the acromial diameter gets reduced, correct?
Yes,
Now, yes. So these two together, maneuvers together, when used, almost 95 to 99% shoulder dystocia, they are taken care of, right?
Yes, yes.
Suppose you have tried both the things with, as you said, 30 seconds for this. So almost 1 minute now. It's not helped. What do you do now next?
Then you have to go in for something called the enter maneuvers, wherein you can introduce your hand posteriorly into the vagina and try to manipulate the shoulders so that they will be rotated into an oblique or a transverse diameter.
Right.
So you have your Wood's screw maneuver, wherein you push the anterior shoulder from behind and the posterior shoulder from in front to rotate the baby in the pelvis.
Right.
And and also the Rubens maneuver, where you just press the anterior shoulder alone.
Yeah.
Yes.
So
And
how does this maneuver help to deliver the posterior shoulder?
again, we are trying to rotate the shoulders of the baby from the narrower anteroposterior diameter to a wider oblique diameter.
Yeah.
So that the shoulders can slip under the symphysis and the baby can be done.
Yeah. For this maneuver, the principle is such that you can see this baby here, okay? This baby which is here. You can see the posterior shoulder is at a lower level, right? So that has already escaped. But you can see the anterior shoulder is at a higher level and that has got stuck with the pubic symphysis. So when you are rotating this, the anterior becomes posterior. So that also comes at a lower level, and that is how the baby escapes, right? So this is what the basic principles. Of course, what not to do, don't get panic. As you said, don't give traction, no pushing and no pulling, right? But only you have to be swift and quick. You have to know all the manuals and you have to get it done in time.
Right? It is also important that you do a cord blood gas for the baby once the baby is delivered. And examine the baby for any injuries, and also documentation is extremely important. You have to document every event, the maneuvers you did in order, the condition of the baby, any perineal tears, PPH for the mother. That is important to prevent litigation.
Right. So I think with this, we conclude our panel. Though I have many interesting cases, I would just take this opportunity to thank all of you. I would just say that yes, intelligent anticipation, that is prediction, skilled supervision, prompt detection, and effective institution of therapy can prevent the disastrous consequences. Of course, not to forget the communication and documentation, as you have rightly pointed out. So friends, thank you so much for your wonderful inputs. And of course, thank you so much all the KFOG, the entire KFOG, I would like to thank. And I would just take this opportunity. Yes, I would invite some expert comments. I can see so many senior members also joining here. But I would just thank all of you and utilize this opportunity and humbly seek your blessings and wholehearted support for my coming elections. The elections are starting from 1st to 10th August. So from West Zone, there are 2 posts. So you have to vote for 2 people. I would request, or rather, I would urge that if you feel I deserve, please do make me as your first choice of the two. So thank you so much once again, and over to you for the further proceedings. If there are any expert comments, if there is somebody senior, madam, I would like to have their expert comments. I can see my dear friend Dr. Mumtaz joining here, and welcome, Dr. Mumtaz. Anybody having any comments, you are welcome. You have to unmute yourself, Mumtaz. You have to unmute. Unmute. Any comments? No, So over to you, Dr. Atulya. I think Dr. Mumtaz, does she want to speak something? Do we have Madam Prasanna Kumari? Yes, please. Madam, yes. Thank you so much.
One comment is in the placenta upper segment, it is in Rita. We will diagnose it only after delivery of the baby. And if it is the plane of cleavage you are not getting,
yes,
in Rita, you open the abdomen and remove that portion of the uterus with the placenta.
Yes.
And actually, there is no need to devascularization, etc. She won't bleed. Because we have given sufficient time, the uterus will be contracted. We have done some 7 or 8 cases over the past 10 years, and 4 of them conceived. Almost half of the uterus has been removed. So, but the uterus looked and behaved normally. And at the subsequent cesarean, it was looking absolutely normal. So we can all do that.
Wonderful. That is wonderful. And of course, it's your pretty long experience, and of course 8 to 10 cases you have done yourself, so that is of course something we also have to learn. As we have already said that uterine conservative surgery, we talked about the P procedure and of course the conservative method what we talked about, but then as you have rightly pointed out, it is only not to take any risk of bleeding we were talking about. Your
But it won't bleed. It won't bleed. It won't bleed. But you have to suture the uterus in 3 days.
You have given us the confidence because of your experience.
All of you can do that.
Yes, and we appreciate sharing your experience. Thank you so much, madam.
And one more thing in shoulder dystocia, especially when you have put in a vacuum and delivered the baby, there can be bilateral shoulder dystocia. So whenever you find that the shoulder is not coming, you have to do a vaginal examination and see whether any of the shoulder is in the pelvis. If both the shoulders are not in the pelvis, you do the restitution. Push the fetal head inside the pelvis and do a cesarean. Cesarean will not be difficult. I have done. It is because both the shoulders are above.
Right.
Cesarean will be easy. So do a vaginal examination, see whether it is bilateral shoulder dystocia or not.
Right.
The ways we can do all these maneuvers. And of this, delivering the posterior arm is the first method if she doesn't deliver after macropedes.
Right, right.
Thank you.
Thank you, madam. Thank you so much for your valuable inputs, madam. And thank you so much for the keen interest in the subject. I'm sure it's lots of inspiration from you for the newer generation. So thank you so much. And over to you, Dr. Atulya and Dr. Monica.
Thank you, madam. I request Dr. Monica to say the word of thanks for today's program.
Thank you, Sneha ma'am, for giving me, Shama madam and Atulya an opportunity to coordinate this webinar. Thank you, Sahiti, for the academic platform. We thank AMOGS office bearers, Kiran sir, Bipin sir, and Pardeshi sir and Parag sir for giving us an opportunity to conduct this under AMOGS office banner. We also thank our chief guest, Dr. Shekharan sir, Kunjumuddin sir, our guest of honors, Aswat sir and Subhash sir, for the gracious presence. Our speakers, Dr. Rani Lakshmi madam and Dr. Sarina madam, for their wonderful academic experts. Our chairpersons today, Dr. Shamla Devi madam. Am I audible?
Yes, yes. Go ahead.
Yes, ma'am. Dr. Shamla madam, Dr. Rachel ma'am, Dr. Prasanna Kumari madam, and Dr. Vijay Lakshmi madam have given their academic inputs, and I am sure all the delegates will have something or the other to take home today. The icing on the cake was a panel discussion on labor room emergencies by none other than Dr. Sneha Buyar, Madam. We also thank our panelists, Dr. Kala Pramod, Dr. Reeti Rajan, Dr. Nimisha, Dr. Reena, Dr. Deepthi, and Dr. Narul Amin for their academic inputs. We thank all the delegates for staying on and for their patience listening. Thank you so much and good night, everyone.
Thank you so much once again, Dr. Rithi, Dr. Reena, Dr. Kala, and everybody, Dr. Nurul, wonderful panelists and wonderful inputs from your side. Thank you so much, and of course, request for your wholehearted support. Thank you so much, Dr. Atulya, Shama, and Dr. Monica, and of course, Saiti for the flawless conduction. Thank you so much.
Thank you, madam.
Thank you, madam.
Thank you, ma'am. Good night. Good night. Thank you, Atulya.
Thank you, ma'am.
Thank you, ma'am.
Thank you.